Hello friends, welcome back to our YouTube channel, and today we are going to discuss local anesthesia part 3, in which we discuss the systemic actions of LA. The systemic action of the local anesthesia is related to the blood or plasma level in the target organ. So higher the blood level means more clinical action. The local anesthetics are absorbed from their site of administration into circulatory system, which effectively dilutes them and carry them to all the tissues or all the cells of the body. So the blood level of the local anesthesia depends on the rate of uptake from the site of administration into the circulatory system. Second one, it depends on the rate of distribution of the local anesthesia into the tissue. And third one, it depends on the rate of biotransformation, that is in the liver. And fourth one, it depends on the rate of removal from the blood. So blood level of local anesthesia, how it depends on the rate of uptake. As if we take the local anesthesia orally, its viability in the circulatory system is not 100%. It's less. And as we know, we have discussed in previous sections that absorption from the intact skin is less as compared to absorption from the injured skin or mucosa. And in case of mucosa, we have discussed in earlier sections that tracheal mucosa has best absorption as compared to pharyngeal mucosa, and esophageal mucosa or bladder mucosa has the least absorption pattern of local anesthesia. Then we is depend on the rate of distribution in the tissue. Then we know in this is also discussed in last section, that we know that the tissues or organs having in the high blood level or highly perfused organs get more local anesthesia, or and also the tissue having the greater mass, they also have the high concentration of the local anesthesia. Then it depends on the rate of biotransformation, and we also know that the ester type of LAs are hydrolyzed by the plasma cholinesterase, and so their rate of biotransformation, so they hydrolyzed and then they excreted nil in the urine. But amide type of LA biotransformation occur in the liver, and when we absorb, when if we taken the orally LA orally local anesthetic agent, then it from the GIT tract it will undergo in the hepatic first pass metabolism. So is which also affect the its blood level. Then rate of removal from the blood, and the is we know that the LA are not harmful. Main parent LA is not harmful as compared to its products are harmful. Like in case of prelocaine, prelocaine is not harmful, but its product toluidine, orthotoluidine, which cause the formation of a methemoglobin, and we know that methemoglobin causes the methemoglobinemia. So products are the harmful, and amide type of LA, 90% is excreted in urine as a product form, and 10% as the parent form, and the products are more harmful as compared to parent compound. So, systemic action of the local anesthesia are the effects on the central nervous system, effects on the cardiovascular system, effects on the respiratory system, and so on. In case of central nervous system, it has anticonvulsant properties. Then it has analgesic effects, and some other effects also on the central nervous system. So first of all, as we all know, the local anesthetic easily crosses the blood-brain barrier. So at a low level or therapeutic doses, the blood-brain local anesthetics does not cause any clinical significant effect on the central nervous system. So then at high doses, that is overdose or toxic level, it causes generalized tonic-clonic seizure. Then it is important to note that that individual patients may respond either more positively or more negatively to doses or blood level of drug that are considered to be normal, example, within an acceptable range. So these actions are based on where that individual lies on the normal distribution curve, commonly called bell-shaped curve. So it has anticonvulsant properties. In the classic overdose reaction to the local anesthesia is generalized tonic-clonic convulsion. Some local anesthetics like procaine, lignocaine, naproxen, or prilocaine, even cocaine, they have shown the anticonvulsant properties, and these occur at the blood level below that at which the same drug produces the seizure activity. Like lignocaine at the 0.5 to 4 microgram to show anticonvulsant property, but same drug at the dose of 4.5 to 7 microgram, it shows the pre-seizure signs and symptoms by causing the depression of inhibitory neurons. And same drug above the level of 7.5 microgram, it will show the tonic-clonic seizure and entire blockage of the inhibitory neurons. So here are the diagrams showing the convulsive activity of local anesthetics. In first diagram, it has shown that cerebral cortex has the pathway of neurons that are essentially inhibitory and others are that are facilitatory, that is excitatory pathway. So state of balance is normally maintained between the degree of effects exerted by these neuronal pathways. And in second diagram, it are the pre-convulsant local anesthetic blood levels. At the pre-convulsant local anesthetic blood levels, the observed clinical signs and symptoms are produced by the local anesthetics, selectively depressing the inhibitory neurons. So, balance is tipped slightly in favor of excessive facilitatory, that is excitatory input, leading to the symptoms including tremor and slight agitations. Then in third diagram, at high convulsive levels, inhibitory neuron function is completely depressed, allowing the unopposed function of facilitatory neurons. Pure facilitatory input without inhibition produce the tonic-clonic activity at these levels. So in this third diagram, the tonic-clonic seizures occur at the toxic level, that is at the dose of greater than 7 microgram in case of lignocaine local anesthetics. And in second diagram, that is showing the pre-convulsive behavior. It's take place at the 4 to 7 microgram in case of lignocaine, and which here is the inhibitory impulses are selectively inhibited. So some tremor or agitations take places. So when if we further increases the LA doses, then it will take the depression of both facilitatory and inhibitory pathway, then producing generalized CNS depressions. So ultimate toxic level of the local anesthetic cause the depression of the central nervous system. So precise action of the local anesthetic within the central nervous system is not known, but it is thought to be inhibitory cortical synapses or directly on the inhibitory cortical neurons. Other actions on the central nervous system are mainly analgesics. So analgesia, local anesthetic, possesses second action in relation to the central nervous system. Administered IV, they increase the pain reaction threshold and also produce degree of analgesia. Then they cause the mood elevations also. Systemic action on the cardiovascular system. Local anesthetics have direct action on myocardium and peripheral vasculature. What's the direct effect on the myocardium? It causes myocardial depression. How? Local anesthetic modify electrophysiologic events in the myocardium in the same manner as on the peripherals. So as the blood levels of local anesthetics increased, rate of rise of various phases of myocardial depolarization is reduced. So myocardial depolarization does not occur. If myocardial depolarization does not occur, that means resting membrane potassium does not change. And resting membrane potassium does not change means no significant prolongation of the phases of repolarization. So, first of all, depolarization does not occur, resting membrane potential does not occur, repolarization does not occur. So, local anesthetics produce a myocardial depression related to local anesthetic blood level. It decreases the electrical excitability of the myocardium, decrease the conduction rate, and decrease the force of contraction. So we can use it as this rhythmic action. It is used as the anti-dysrhythmic agent. So the therapeutic blood level of lidocaine for anti-dysrhythmic activity range 1.8 to 6 microgram per ml. Lidocaine is administered IV as a bolus dose 50 to 100 milligram at the rate of 25 to 50 milligram per minute in the management of ventricular tachycardia and ventricular fibrillation. The dose is based on the 1 to 1.5 milligram per kg body weight every 3 to 5 minutes and is frequently followed by continuous IV infusion of 1 to 4 milligram per minute. Signs and symptoms of local anesthetic overdose will be noted if blood level rises beyond 6 microgram per ml. Same as this have direct effect on the myocardium by decreasing its electrical excitability, decreasing its conduction rate, decreasing its force of contraction. In similar way, it has direct action on the peripheral vasculature. So cocaine is the only local anesthetic that will produce the vasoconstriction. Otherwise, all the LAs will produce the vasodilatation, and due to which the increased blood flow will uh, decrease the local anesthetic level at the site of deposition, and it distributed it from away from the site of deposition to other tissues. In case of respiratory system, the local anesthetic have dual effect. And low doses is cause direct relaxation on of the bronchial smooth muscles, and at the high doses, respiratory arrest occur due to the CNS depression. So comes to drug interaction. In general, CNS depressants like barbiturates and anxiety drugs or opioids, when these are administered in conjunction with the local anesthetics, they lead to potentiation of the CNS depressant action of the local anesthesia. So whenever patient give the history of taking and history of antidepressant, that means he is already taking antidepressant and he is asking for tooth extraction, and we have to give the LA before that, then we should taken the medical consent from a medical practitioner about giving the LA, as LA can increase LA's LA's depressive activities can be increased, as LA has the CNS depressive effect if its toxic level reaches or if it's overdose occur. Then as we know, some drugs and LA, they share the common metabolic pathways which produce the adverse reactions. So, the both ester type LA and depolarizing muscle laxant like succinylcholine require plasma pseudocholinesterase for the hydrolysis. So, prolonged apnea may result from concomitant use of these drugs. So, we have to take the proper history before giving the local anesthetic agents. Then comes to malignant hyperthermia, which is a pharmacogenic disorder in which a genetic variant in the individual altered that person's response to certain drugs. So, acute clinical manifestation of malignant hyperthermia will include tachycardia, tachypnea, unstable blood pressure, cyanosis, respiratory and metabolic acidosis. Fever will occur, muscle rigidity will occur, or death may be occur. So mortality rate is 80% in 1980s, which have been decreased to less than 5% in the 2006. So some anesthetic drugs can trigger the malignant hyperthermia in some individuals. So we should be careful while giving the LA agent by taking the proper history of the patient. So here are the diagrams showing some local anesthetic agents like cocaine, procaine, lignocaine, bupivacaine, prilocaine, and their onset of action tells which are medium acting, short acting, or rapid acting, and their duration also is given, like tissue penetration, and their main unwanted effects are also here. So like this, cocaine has cardiovascular and CNS effects due to block of the amine uptake, and procaine causes restless, shivering, anxiety, convulsions. In CBS, it causes bradycardia, decreased cardiac output. Lignocaine has less tendency to cause cerebral nervous system effects. And bupivacaine, like lignocaine, but have the greater cardiotoxicity. So prilocaine has no vasodilator effect, but may cause methemoglobinemia, which I have told you to its product orthotolidine. And it's a my type LA, so it's the give the product orthotolidine, which form the methemoglobin, which cause the methemoglobinemia. So these are the some local anesthetic used in clinical dentistry. Here are the ingredients in an LA solution, which we commonly used. In normally used LA solution, local anesthetic solution, we have the local anesthetic agent, which is lignocaine hydrochloride, which is 21.3 milligram. Then we have the vasoconstrictor, which decrease the absorption of local anesthetic into the blood by causing the vasoconstriction and provide us bloodless field. And it's mostly used as adrenaline 1:80,000 concentration. Then we have preservative in our solutions, which is sodium metabisulfite 0.5 milligram, which reduce the oxidation of the adrenaline. And then we have preservative to increase the shelf life of these our local anesthetic solution. And we use the methyl paraben for that. That is 1 milligram. Then sodium chloride 0.6 milligram added to provide the isotonicity to the solution to the tissues. And as it's a lignocaine hydrochloride acidic agent, So isotonous T added. Then sodium hydroxide to maintain and adjust the pH. Then thymol added as a fungicidal agent. Then distilled butter for the dilution. Nitrogen bubble also added 1 to 2 mm in diameter. They prevent the oxygen from being trapped in the cartridge and potentially destroying vasopressor or vasoconstrictor. So these are the here ingredients. So this is our today's lecture. Hope you all understand. Thank you.